Hi everyone, my name is Robyn Allen. I'm a registered physiotherapist in Ontario, Canada. I practice at an adaptive riding center called Hope Haven, where I'm also the program manager. And in my volunteer time, I am a national para-equestrian dressage classifier for Canada. So I have my hands in the world of equines from a few different angles representing individuals with unique abilities. I'm so pleased to be able to share with you some information on the tool that I use most in my current physiotherapy practice called Hippotherapy, and how it can be an effective therapeutic tool for children with CDKL5. Even though this is a snapshot of what hippotherapy is all about, and considering the unique abilities that each child with CDKL5 presents with, I hope that this presentation will inspire you to look further into this amazing treatment tool for your child if you're a parent, or for your patient if you're a healthcare professional. Here are the objectives for this presentation: to define the term hippotherapy and who should be offering it as a therapeutic tool, to understand why a horse can be such a useful therapy partner, to outline the considerations when determining appropriateness for hippotherapy for children with CDKL5, and finally, using two client examples, create a picture of how a therapist may use hippotherapy to progress the development and function of a child with CDKL5. I often get asked jokingly whether we use hippopotamuses in this type of therapy, so let's just clear that up right now. The term hippo is an ancient Greek meaning for horse. A group of European therapists in the 1960s who were using this therapeutic technique with horses thought it would be very clever to pair the word hippo with the word therapy, and thus we have the term hippotherapy. What is hippotherapy? Hippotherapy is defined as the use of equine movement to help achieve functional goals as part of an overall therapy plan with a regulated health professional. There's no such thing as a hippotherapist. This would be an improper use of the term. Hippotherapy is a therapeutic tool that is used specifically by trained physiotherapists, occupational therapists, and speech-language pathologists, just as they would use any other tool within their toolbox. Therefore, when describing to a friend or even an insurance company what your child's therapy entails, the proper description would be something like this: Emma is doing physiotherapy with the use of hippotherapy. You want to make sure you are describing the type of therapy first and the tool second. Also, just as a disclaimer, this presentation will be more biased towards physiotherapy goals and treatment effects, as that is my area of practice. As with any treatment or therapeutic tool you are considering for your child or your patient, you want to make sure there is research backing its effectiveness. There's increasingly more high-quality research validating the effectiveness of hippotherapy. Unfortunately, you'll be hard-pressed to find studies done specifically on hippotherapy in children with CDKL5. However, what we can do is take what we know about children with CDKL5 with regards to likely assessment findings and functional goals, and consider findings from other research involving hippotherapy with similar populations. Because this is a family conference, we will not be delving into too much of the specifics of the research. However, the references I have used for this presentation are all listed at the end for you to look up in more detail if you're interested. It is also worth clarifying that hippotherapy is not teaching the skill of riding, and therefore is distinctly different from programs you may hear about, such as therapeutic or adaptive riding. These programs are led by a certified equestrian instructor, not a regulated health professional. Why use a horse? Here is a picture of a client of mine we will call Joey. He is a primary wheelchair user with no active use of his lower extremities. Yes, that's true, even though, as you see in this picture, he is able to negotiate a 4-point position on top of a horse. I chose this picture for the facial expression that portrays his, but also his team's excitement and sense of awe at what he's able to accomplish. This is one of the most important points I'm going to make through the whole presentation, and if you have a child who is wheelchair dependent, you will realize the impact of this statement. When Joey is mounted on his horse, he is able for the first time to be the highest in the room, be the positive center of attention, and feel a true sense of pride. Think of how that affects his self-esteem and sense of worth. This child is excited to come back to physio each week. He's motivated to do more and do better, not only for himself, but for his entire therapy team, in particular his horse. This therapeutic tool of hippotherapy is more of a team effort than any other clinical tool I've ever used. We have the client and horse working as one, the therapist and extra sidewalker facilitating positioning and maintaining safety, And we have a horse handler that is in charge of what the horse provides to that child with regards to quality and variations of movement, and again, safety. Consider the socialization, relationship, and confidence building opportunities that can be encouraged within these sessions. And lastly, it's not therapy in that child's mind. It's just fun horse time, and who wouldn't want that? Now let's go through the technical reasons why we use a horse. So let's get our thinking caps on for this. Horses have unique movement qualities that are directly transferable to their riders. A horse's movement has 4 important characteristics to it. It's symmetrical, rhythmic, repetitive, and consistent. These characteristics are all being transferred to the rider like a template, assisting their nervous system to create its own appropriate motor responses. As humans, our most efficient and effective movement requires those same 4 characteristics. However, an individual's disability or impairment will determine how those characteristics are presented. For example, if you have a significant scoliosis or a curvature of your spine, you will not be very symmetrical with your center of balance, your gait, or even your breathing mechanics. If you have a spastic cerebral palsy, so very high tone in all or parts of your body, your movement will not be rhythmic nor consistent. If you're severely hypotonic, so low tone with little active purposeful movement, you haven't even experienced any of these qualities yet, not even in an inefficient way. So in all of these examples, the horse is able to lend these characteristics to the rider's nervous system in order to assist with creating brand new motor patterns or helping their existing patterns to become more efficient and effective. When a rider sits on top of a horse's back, the movement provided to the rider's pelvis is a 3-dimensional pattern that mirrors mature, efficient human gait. These 3 planes of movement are, and if you picture my hands on the side of a child's pelvis, lateral or side flexion through the frontal plane, anterior and posterior movement through the sagittal plane, as well as rotational movement through the transverse plane. Now, on top of those 3 planes of movement, the horse also gives the rider a vertical displacement, so up and down movement, as well as movement through space, whether that be forward, backwards, or even lateral translations. Those translations through space are dependent on the direction the horse is being asked to move or what position the rider is in on top of the horse. These multidimensional movements that the horse provides the rider can be manipulated by the therapist in order to best facilitate the response from the rider they are looking for. Examples of manipulating the movement would be changing the tempo of the horse's gait, increasing or decreasing their stride length, doing transitions from walk to halt or vice versa, but also determining how sharp or soft of a transition to make it, adding in bends, circles, serpentines. Changing the surface underneath the horse as a soft level arena floor requires a much different response in a rider than a hard-packed driveway, a hilly terrain, or even stepping over objects like poles. The therapist may also manipulate the movement through their choice of horse to use. For a child who needs moderate support to maintain an upright position and has only fair head control in this position, the therapist will want to choose a horse with very little vertical displacement, so a smooth ride, a horse that also has even planes of movement, if not maybe a little less anterior posterior movement to help control that momentum. And then with regards to manipulating the movement of the horse for this specific child, the horse handler is going to be asked to ensure a very slow tempo, only as much as the child's postural stability can control, and transitions to be made very slowly and smoothly. Another indirect way to manipulate the horse's movement is to actually change the position of the rider on top of the horse. They can be forward facing, backwards facing, side sitting, supine, so on their back, prone on their belly, hands and knees, kneeling, and many other developmental positions. We will get into some benefits of a few different position options later in our client examples. So we have reviewed the important movement qualities of a horse and how a therapist can manipulate them. What else does a horse provide? For every minute of movement on a horse, a rider is provided with 100 steps of highly organized motor and sensory input. That means if a hippotherapy session is 30 minutes in length, The child is provided with up to 3,000 steps of input sent by their sensory systems to their brain, which then it tries to process it all and respond with appropriate motor responses. What does that mean? For a child that walks very short distances, only a few times a day with assistance such as a walker, a short hippotherapy session can provide them with a massive motor learning opportunity for their nervous system, which, as you can imagine, can be quite fatiguing both physically and mentally. For a child that doesn't ambulate at all, think of the brand new high-quality movement experiences this child's nervous system is provided with. Or even think about the fact that for the first time they are moving through space and being asked to attempt to stabilize their trunk, which is normally supported by their wheelchair, stroller, or car seat. This may be an exciting yet possibly terrifying experience for the child. I've underlined the word input on this bullet point because this is something that typical clinical tools cannot give these children. Most clinical tools challenge a child's sensory system to help their brains figure out how to process and respond with output. However, they don't provide a bit of a blueprint or a cheat sheet of motor planning to help the child get there like a horse can. Also difficult to reproduce in a clinic setting is our last point, the fact that hippotherapy provides a multi-system impact. Here's an overview of the many systems that are affected, and often simultaneously. We have our musculoskeletal system, which involves our muscle strength and endurance, as well as our bony structures, in particular the alignment and mobility of our hips, pelvis, and spine. Our central nervous system, which takes in all of our sensory inputs from smell, touch, vision, vestibular, which coordinates our balance, proprioception, which is our perception of where our body parts are in space. Then our brain processes these sensory inputs and triggers efficient and effective outputs. And finally, our autonomic nervous system, which regulates our respiration, circulation, digestion, among many other bodily functions. To put this all very simply, there's not one system that hippotherapy does not affect. And in reality, our systems must all figure out how to work together in order to appropriately process information and then produce effective outputs. I've thrown in this last thought as I know this question will be lingering on the minds of those of you who have heard about these machines. Can mechanical horses give the same benefits? The more advanced mechanical horses have succeeded in providing some quality three-dimensional movements. However, they can't move through space. The movement can't be well manipulated by the therapist. They are able to vary their tempo, but that's about it. They can't change direction, bend, back up, move laterally. They don't smell. They aren't warm with soft fur and coarse manes and don't breathe underneath you. They can't respond to help balance the rider on top of them. And of course, they don't provide all of the benefits that comes with working with live animals in a natural setting. So no, they can't replace the real thing. However, there are some great benefits a mechanical horse can provide. Say if the client is not appropriate to be on a real horse for physical or even behavioral reasons, if you're attempting more risky positioning for assessment purposes, or horses just aren't your thing. So now we have a pretty good understanding of what hippotherapy is and the reasons behind why the horse is such a useful therapy partner. Is every child appropriate for hippotherapy? Definitely not. However, I bet it's way less limiting than you think it is. Let's look at what needs to be considered in this decision process, specifically for children with CDKL5. First of all, we need to look at client considerations. These 4 points do not stand alone. We need to consider each one individually and then how they work together to determine what the risk may be. We know that CDKL5 is a seizure disorder, and for most children, they are considered varied and uncontrolled. Therefore, the chance of experiencing a seizure while on the horse is quite high. If the child does not show signs of significant seizure stabilization, we must be confident that our sidewalkers can easily perform an emergency dismount without hurting the child or themselves. Therefore, the size of the child becomes a very important factor. In these situations, I ask for a video of a child's typical seizure so I know what to expect and determine whether it will be manageable to get them off the horse quickly. It is often thought that a child must be able to sit independently without support to be appropriate for hippotherapy. Again, the size of the child will play a significant role in this decision-making, as well as what the functional goals of the session are. With a small child where we feel confident that we can physically and safely support their upright posture, that can be a very appropriate treatment choice. Or we may not even have a plan for an upright position at all to begin with. For example, a therapist can use a supine position, so on their back, to work with the child's protective and equilibrium reflexes, meaning they are still being challenged to stay centered and balanced against the oscillating horse underneath them, but in an anti-gravity position. Or maybe the therapist wants to work with the child in a prone position, so on their belly, to assist with sensory regulation, while the child literally embraces the breathing rib cage of the warm horse underneath them. There is no specific level of sitting independence required in these situations. The therapist just needs to make sure they can be safely supported while in those positions and can be dismounted quickly if need be. Now let's look at team considerations. The therapist must be experienced and confident that all of the above client considerations, as well as the team and facility concerns, are well thought through prior to even attempting to mount the horse. The horse handler must be very familiar with the horse they are leading and well trained in emergency situations, such as a dismount due to a sudden seizure. The sidewalkers must be well trained, experienced, and in tune with what the therapist is asking of them. They also must be physically able to support the child for the entire duration of the session, as well as perform an emergency dismount if required. And last but not least of the team is the horse, who needs to have an appropriate disposition to handle 3 people surrounding them, a lot of shifting around on top of their back, and the possibility of a seizure, as just like some dogs, horses are able to detect them coming on. So we need to think ahead as to how a particular horse may react if this is the case, and choose the one that will stand in their tracks. And the last area of consideration is the facility. We have families listening to this presentation that are from many different areas of the world, so I can only speak on this point as to what I am familiar with here in Canada. We have facilities here that have very strict seizure policies that would automatically create a barrier for many children with a CDKL5 diagnosis. At the facility where I practice, we have devised a seizure form that must be signed by the child's doctor, preferably their specialist, where they are able to indicate whether they believe hippotherapy would be appropriate for this child or not. Usually, if we get to the point of asking for this form to be signed, we have already mitigated the risks. However, it's an extra layer of protection for everyone, as a specialist may consider a medical factor that we have not. The accessibility of the facility is another factor to consider, as your child may require a mounting ramp in order to be mounted safely, or maybe you'll need to make sure you have an accessible washroom or changing facilities available. Let's now look more specifically at some potential positive effects of hippotherapy, specifically for children with CDKL5, through the review of 2 different client examples. First off, we have 3-year-old Bryn with a diagnosis of CDKL5. She can experience seizures multiple times per week and sometimes multiple times per day. She is very low tone with little active functional movement, and she is nonverbal. However, she can definitely tell you how she feels through her sounds and her eyes. When placed into a sitting position, she has what I call the gravity is winning position, where her back slumps and her head drops forward, as she just doesn't have the motor ability yet to generate an upright spinal position with her head aligned on top. Maybe you can guess what this can lead to. If you thought scoliosis, you are correct. As a side note here, it is imperative that you are always encouraging a proper spinal position or alignment when working on independent sitting as well as in supported sitting. You don't want gravity to start to take over and create those types of structural changes. At the first assessment for Bryn, Mom and Dad had long-term goals of independent sitting. This goal is so much more than just being able to sit up straight. Having the ability to generate, regulate, and maintain upright posture against the forces of gravity and all the different momentums coming at you means you then have the ability to use your extremities more effectively, say for self-feeding or playing with toys. You also create a more effective respiratory system, increased ability to generate sound, improved swallowing function, and the list goes on. So helping Bryn to start to generate an upright posture is where we started. Here are 3 pics of Bryn doing her first hippotherapy session. In sitting, I have complete control of her head, and the other sidewalker has control at her pelvis while also facilitating her into an upright posture. She is wearing a therapy belt, which offers a couple of different functions. My side walker has a hand on it at her pelvis, as it's a reliable place to grab if needed, but it also serves as a little extra external support by slightly increasing her abdominal pressure. You'll see in the third picture, I also have Dad following closely, as he will be able to alert me to signs of discomfort or anxiety or even a seizure coming on, as we are still getting to know Bryn at this stage. This first day, we are getting Bryn comfortable and providing with as much support as she needs to feel safe and hopefully enjoy it. This day consisted of upright sitting for very short bouts of movement at a time and giving her lots of rest. She was responding extremely well, showing contentment, so we went a little bit further. We also incorporated work in supine as well as prone, which allowed her to experience a whole new sensation to her vision and vestibular systems. Even in these anti-gravity positions, her reflexes were challenged to keep her body in midline, so still lots of sensations to process and work for her motor system to do, even though it looks like she's taking a rest. A few sessions later, we were then able to prop Bryn's arms under her chest and encourage her to lift her head and look up at Mom, who was following behind. Not only was this a physical accomplishment that would have direct effects on her upright posture, but it was also exciting that she was responding to the request to lift the head and seemed to enjoy the fact that her whole team was willing her to stay up for longer and longer each repetition. Here is a very short 40-second video clip taken by Mom a few sessions down the road, and I'll play this a couple of times in a row while I'm talking so you can look back at certain points. You will see now, compared to that first picture, that I'm giving Bryn much more freedom with her head control. We are keeping the horse's movement slow with smooth transitions and allowing her time to correct her positioning. We have her in a backwards sitting position here to stimulate her extensors of her trunk, as momentum will want to bring her body towards the horse's bum. Then when we add in transitions, we see that with every halt to walk transition, her nervous system will have to learn to fire on those extensors much more quickly to keep her upright. Sometimes, as you'll see, her head gets taken into the direction of momentum. However, then we give her a chance to right it, which you will see her do independently. It also looks like I have a lot of hand support on her trunk. But in fact, my hands are almost feather touching her chest and back, only to minimize the amount of postural sway, but allowing her body to figure it out within my boundaries. You can also see that my side walker is only on her belt as support if needed for safety. He is not in any way influencing her pelvic position as he had to initially. We are extra lucky if the horse has at least one poop during a session, as that's always the highlight with any child, especially when they're facing backwards. And guess what? All of this mobility and stimulation of postural muscles while on the horse helps with, you guessed it, the child's own bowel movements. Now let's move on to our second child example. And this one has a little bit different abilities. This particular child does not have a diagnosis of CDKL5. She has another neurodevelopmental diagnosis, but with similar characteristics. So therefore, we can apply these same goals and treatment methods to children with CDKL5 who have achieved a little more advanced motor development. This is Tatum. She is 10 years old and has a diagnosis of Pallister-Killian syndrome, or PKS. Some of the findings she presents with are hypotonia, much like CDKL5, clubfoot, is nonverbal, and has cognitive delay. Functionally, she is able to walk short distances on even ground with her walker. She's able to cruise on furniture or walls within her house and may carry objects in one hand, usually her right, while moving, as long as the other hand is free for stabilizing. And you can see a little bit of that in the picture. Her family has long-term goals of having her walk independently on even surfaces, safely climbing and descending stairs with railings, and being able to more functionally use her upper extremities for purposeful tasks. To accomplish all of these tasks I just mentioned requires being able to generate, regulate, and maintain her postural stability. Tatum is able to generate a proper upright sitting position with some facilitation to get her pelvis sitting where it needs to be, which allows her lumbar spine to arch in and everything else to stack on top in proper alignment. She can actively get there when prompted, but over a small amount of time or with any extra challenge such as stabilizing against changing momentums or doing a reaching task, Her system fatigues and loses it easily. This is when her balance is affected and her hands want to reach out for something to support her trunk. The picture on the left here is her preferred posture, and it's easier for her due to her low tone. This sitting posture is a mild version of the gravity is winning posture that we talked about with Bryn. On the right is Tatum after a few months of hippotherapy and is able to not only generate that posture on her own, but she will maintain that correct posture for a much longer period of time, even when challenged with momentum changes such as gait transitions, circling, and even reaching tasks while moving. She is a very difficult one to engage in tasks due to her cognitive ability. Therefore, we have to use twinkly lights and sensory toys to motivate her to reach and grab. She is also very right-sided dominant, almost neglecting her left side. Therefore, we include forced activities and attention to her left, as well as manipulating the horse's movement to make her left side engage more. Remember that characteristic of symmetry that is so important for efficient movement. That is what we were trying to accomplish here. Unfortunately, I don't have a picture of Tatum for this next task. However, to give you an idea of where she is progressing to, this boy is showing a side-sitting position, which gives a much smaller base of support through the pelvis, harder to maintain that proper upright posture, and his brain now has to process all of the incoming visual and vestibular information in a new way to maintain his balance. Once achieved without hand support, we can add on those reaching tasks again to challenge the system further, much like he's doing in this picture. Hopefully, these two very different client examples were able to present a picture of how a therapist may use hippotherapy to assist in the progression of development and function for a child with CDKL5. As I had mentioned in the beginning of this presentation, this has been a snapshot of how hippotherapy can be an effective therapeutic tool. And if it is something that you think would benefit your child or your patient with CDKL5, then I encourage you to reach out to a local PT, OT, or SLP, depending on your goals, and find out some more. Thank you to the CDKL5 Alliance for your amazing work and giving me this opportunity to share this information with your members. Thank you all for joining me through this presentation, and I wish all of your families the very best.